Two more minutes.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत्।
A warm welcome to the audience and experts on the panel to True Wealth's Obesity Awareness Program on the eve of World Obesity Day. Obesity, once considered as a cosmetic concern, is now recognized as a complex medical condition impacting virtually every organ system in the body. Obesity increases the risk of diabetes, critical cardiovascular diseases, gastrointestinal complications, infertility, PCOS, respiratory disorders, joint pain, mental health issues like depression, anxiety, low self esteem, colon, ovarian, and other cancers, and much more. It is characterized by excessive accumulation of fat, often resulting from a combination of genetic, environmental, and behavioral lifestyle factors. Hence, management of obesity requires a holistic approach that addresses the complex interplay of biological, psychological, social, and environmental factors contributing to weight gain and related health issues. By addressing the root causes of obesity and implementing integrative strategies that encompass lifestyle modifications, medical interventions, and surgical options, individuals can achieve sustainable weight loss and improve their overall health and well being. Obesity, however, is rapidly increasing world over, and so are its critical complications. Which is why, on the eve of the World Obesity Day, True Wealth team brings to you a panel of renowned experts who will be sharing their experiences and insights with you, which would help you make informed choices in managing weight and related complications. A quick introduction of me, having 20 years of global experience across continents, I firmly believe that nutrition can be modern day's most effective and safe therapy in managing lifestyle, autoimmune, and infectious diseases. With an MBA in marketing and master's from Scion Hospital and a postgraduate course from Symbiosis and a certificate course from Stanford University, I work I've worked across therapy areas, helping many in managing, controlling, reversing, preventing various ailments, especially PCOS, weight loss, diabetes, digestive disorders, arthritis, and more. I've, of course, anchored more than 400 patient programs with 1,000 plus great faculty across the globe. And the idea was to spread authentic disease and integrative treatment information with the purpose of spreading health and happiness. Sarve bhavantu sukhina, sarve santu niramaya. To take the mission forward, TrueWealth Integrative Healthcare was founded. TrueWealth Integrative Health Centers provide holistic and personalized nutrition consultations with eminent medical, surgical, and nutrition experts to control, prevent, and reverse lifestyle, autoimmune, as well as infectious diseases to reach the ultimate goal of holistic health and happiness. With that mission, on the World Obesity Day, I request our first speaker, Dr. Prashant Salvi, and I take the privilege of introducing him. Dr. Prashant Salvi is minimal invasive metabolic and bariatric surgeon at the Jupiter Hospital in Thane. He's MS General Surgery, extensively trained in bariatric and metabolic surgeries at Asia's highest volume bariatric center with formal university fellowship in minimal access laparoscopic surgeries. Dr. Prashant Salvi has an experience of managing more than 2,000 bariatric cases. His focus is comprehensive obesity care. Dr. Salvi is actually going to share with us types of surgeries and procedures that can be effective in managing obesity, especially in critical cases. He will also educate us on the pros and cons of the procedures and help us overcome the fear of surgical procedures when they are really needed. So, proud privilege again to welcome Dr. Salvi here, and really over to you.
Thank you so much for having me here, and good morning, everyone. Thank you so much for the lovely introduction. So, we all know that obesity is a chronic disease. If you see what is obesity, it's a chronic progressive disease. And when we talk about the various management of obesity, there are multiple modalities of management. The first backbone of any treatment for obesity is the diet and exercise, and then accordingly, in case if it doesn't work out well, then that the option what we have is a surgical option. Now, when you talk about surgery, many people get feared with the idea that surgery for weight loss, and then they feel why surgery and how that can be beneficial and what are the complications, what are the. So there's a lot of stress when you talk about surgery for weight loss. But I would definitely like to say that bariatric surgery is not cosmetic surgery. We are not here to make people look good. They eventually look good when they start reducing their weight. But this is not a cosmetic surgery, and it's a surgical treatment option for those who have tried everything, but they have failed to lose weight. and then the surgery comes in action, and that's how the patient starts losing weight. So here we're not talking about only weight loss, but we are talking about the comorbidities the patient has because of the weight. See, obesity is called as a mother of all diseases. If you see from the head to toe, there are so many problems which obesity is actually responsible for. You start with migraines, you start with depression, you start with obstructive sleep apneas, you start with non-alcoholic fatty liver diseases. Probably my rest of the panelists are going to be talking about that. But if you see overall, there are 13 types of cancers which are actually related to obesity. I mean, obesity can be responsible for that. So, in view of that, we call obesity as a mother of all diseases. And when these patients they land up to our OPD, we do their body fat analysis, and based on their BMI, based on their diabetes comorbidities, based on how long they are diabetic, what other comorbidities they have, based on that we take an analysis and we do a overall analysis, and then we plan for a surgery. Now, surgery, not everybody can undergo surgery. There are some guidelines based on which the patient can undergo surgery. So, if the patient's BMI is above 30 and the patient has comorbidities like diabetes, blood pressure, either one of the two or maybe two of the comorbidities, that patient can, as per the guidelines, the Indian obesity guidelines, can undergo surgery. If the patient's BMI is above 35 and the patient do not have any comorbidities, those patients can also undergo bariatric surgery as per the guidelines. Now, when you talk about the surgery, so like what I said, these are the criteria. So above 35, above 30. So there are a lot of research going on, and people have already started doing bariatric surgery for lesser BMI patients, patients who have less than or more than 20, 27 BMI. They are not into obesity category one or two, but then these patients are poorly controlled diabetic. They have 100, 200 units of insulin, but the sugars are still not controlled. So these are the lean fat Asian individuals wherein bariatric surgery, metabolic surgery can help reverse the diabetes, and that's how these patients can also undergo bariatric surgery as per the guidelines. Now, in general, when you talk about surgical aspects, so surgery in no, in general terms for the common man, it is only of three types. One is a restriction, when you restrict the amount of food. The other is a malabsorption, and the third one is a combination of restriction and malabsorption. Now, when you talk about the surgical restriction, so that's the sleeve gastrectomy. If you see the amount of stomach which we cut it out and take it out, so that's the sleeve which is left behind. This is the stomach which is left behind in the body. Ideally, the capacity of the stomach would be around 1 to 1.5 liters. And when we decrease the size of the stomach by removing laparoscopically, we remove this excess portion of the stomach. When we remove the stomach, what is left behind is around 70 to 140 ml. Now, that's a kind of restriction patient when you do the surgery. The other kind of restriction is a intragastric balloon, wherein we put in a balloon, inflate the balloon to a level of 500 ml or so, and that causes restriction, and the patient doesn't cannot have much of the food because a lot of restriction happens, and the patient stops eating immediately after limited amount of food. The third procedure is also called as an endoscopic sleeve gastroplasty, wherein we suture the stomach from inside and we decrease the size of the stomach. Now, when you see surgical, how the patient looks after the sleeve gastrectomy. So, if you see the stomach is already cut, what you see on the left side of the screen is the stomach which is there in the body. The capacity of this stomach is around 70 to 140 ml. To your surprise, what you see on the right side, it is the stomach which is cut and taken out of the body. This is laparoscopically done. Now, if you see that, that is the stomach which you have inflated with the normal saline. If you see this stomach, you assume how much water it is filled. If it's taken up, it is 1 liter of saline which is already instilled in the stomach. So you can imagine if the stomach is distended or we start overeating, how much the stomach can distend. So even if 1 liter of the stomach is taken out, there's still enough space, and that is why the restriction comes into action. The patients are not able to eat that much of food. And what happens after that? See, we are not keeping the patients hungry. Ideally, any patient or anybody, even all of us, require only 2000 calories for the daily metabolic activity. But if you see what you eat from morning till night, we would be obviously crossing above 2000. And whatever excess above 2000, it is going to be deposited as fat. Now, when you do a restrictive surgery, what happens is the maximum the food the patient can have is around 800 calories or so, approximately. Now, the body requires 2000. What we are giving is around 800 calories or so, and the stomach is full with 800 calories. But the body is still falling short of 1200 calories. And these 1200 calories would be taken down by the fat which is deposited. It starts channelizing to give you energy. So, in simple terms, patients eat less because there is no space. They are still more active. They are still losing weight because the body's fat is getting channelized to give them energy. So, that is how the restriction works in action. The patients are not starving, they are full because the size of the stomach is small, and that's how restriction acts. Now, this the second surgery. It is called as a malabsorptive surgery. When you see in the screen, this is the stomach, this is the esophagus. That's the junction of the esophagus and the stomach. So, off the entire stomach, we just take a small pouch. We make a small pouch surgically, and that pouch is approximately around 80 ml. So, imagine what are we talking about from 1 to 1.5 liters. We make the stomach pouch to around 80 ml. We measure a portion of the small intestine and we join it over here. So what happens? Food doesn't enter in this part of the stomach. The entire length is bypassed. So the food from the esophagus coming into the small narrow stomach pouch which we have created and directly enters into the small intestine. So because of this, we create a malabsorption. Now, why we create a malabsorption? Because let's see, these malabsorptive surgeries are done for patients who are super obese. They are about 150, 200 kgs. Now, for these patients, when we do a malabsorptive procedure, the food is not entering into this portion. The food is not getting absorbed, and the calories also are not getting absorbed. So the lesser intake of food plus there is a bypass, then this patient start decreasing the weight. Now, why we do this surgery? If the patient is highly diabetic, if the patient is super obese, these are the surgeries which they're going to be giving them better benefit. So even if the patient is more than 100 kgs excess body weight, let's say a patient's weight is 200 kgs, and his ideal weight should be around 90 kgs. So he's actually on 110 kgs excess. Now, these are the patients when we do this malabsorptive procedures, they can lose more than 100 kgs also. And that's how the malabsorption kicks in. They lose the body fat, they lose their excess body weight, and also along with that, they decrease their insulin requirement. Probably on the second day itself after the surgery, the insulin resistance decreases, and these patients go home without any medication for their diabetes. Couple of months, even the medicines for hypertension decreases, their cholesterol become better, the fatty liver reverses. So all the comorbidities which these patients have because of excess weight, they also reverse, and that is malabsorption. Now, if you see in the body, how does it look? This is one of our patients only. That's the liver, which is fatty. The liver has been, what do you say, retracted because of the retractor. This is called a Nathanson's retractor. That's all the mental fat. What you see here is the stomach pouch, which is created laparoscopically, and that's the remnant stomach. So what you see, the food is entering from the esophagus into this narrow stomach pouch and directly entering into the small intestine. So this entire bypass segment doesn't receive food, and that's how the malabsorption kick in. Now the third type of surgery is called as a Roux-en-Y gastric bypass. So what's Roux-en-Y gastric bypass? If you see in the picture, that is the only portion of the stomach which is left. The rest of the stomach is a remnant stomach where food is not entering. So if you ask me how much is the capacity of the stomach, it's around 30 to 40 ml. Now, if you see, it's very scary to understand that when the stomach size is 1 to 1.5 liters, from there we are coming only to 30 ml. But understand that's a restriction plus malabsorption. So we're trying to restrict the amount of food the patient can have, plus the food is not entering into this stomach. This food is directly entering into the small intestine, and then we may have a joint here. So the remnant part of the stomach, the gastric juices, the bile which is coming from the liver, it is getting mixed over here, and that's the digestion starts from the common channel. Now, why are we doing this surgery? So, this, so what you see it inside, this is only this much portion of the stomach is there left, and the remnant part of the stomach is then connected down, and that is the small bowel. So the food entering from the small pouch directly into the small intestine. So why are we doing these surgeries? Why are we doing restriction? Why are we doing sleeve? Why are we doing combination of two? So it all depends on what is the patient's BMI, for how long the patient have been super obese or obese, how many years the patient is on diabetic medications, what other comorbidities the patient has, what exactly is the body fat analysis. Based on these, we try to decide the surgery as per the guidelines given by the Society of Obesity Surgeons. So we have international guidelines, we have national guidelines. Based on that, we pick up patients and do the surgery. Like one particular thing cannot fit all. This is exactly how one surgery cannot be good for everyone. One patient would be getting benefited with a sleeve, not necessarily the other patient also would be getting benefited with the sleeve. So surgery is decided by the surgeon who we feel that this patient can have this kind of bariatric surgery and will have much more benefits. Because what happens at the end of the day, if you do a sleeve gastrectomy and the patient is not motivated, there is no lifestyle change. 2 years down the surgery, these patients are going to come with weight gain. So that, like I said from the start itself, that bariatric surgery, it's a surgical option for patients who are not having benefit because of conservative measures. But you need to understand that lifestyle modification is the backbone of any bariatric or non-bariatric or any weight loss program. So if the patient improves their lifestyle, does a minimum of 45 minutes of walking every day, counts his calories, and that's how the patient will start maintaining the weight. Most important, when a patient undergoes a bypass, the nutrition is very, very, very important because the food is not going into the channel where the absorption occurs. This patient can have deficiency of B12, calcium, multivitamin deficiency. This patient can go into sarcopenia. So most important after surgery is the supplements, because when you do a malabsorption or when you restrict the amount of food, there has to be an adequate supplementation for this patient. So initial couple of years, like for the sleeve gastrectomy, we give supplement only for a year and a half, and for a bypass patient, these patients require a lifelong supplementation. But these supplementations later on we can convert to natural supplements. For the initial 1 2 years, the support is in the form of multivitamins, calcium, B12, protein supplements. So all these things, the nutrition plays a very important role. Because when the patient starts losing weight, along with weight loss, there is 1 to 2% of muscle loss, which also happens. Invariably, it has to happen because it happens. Now, we cannot afford to have these patients lose their muscle mass, and that is why when we give supplements, the muscle mass is intact, and the patients only lose the fat mass. And that's how the bariatric surgery helps. So the positive effects, definitely there's significant weight loss. There's improvement of type 2 diabetes on the second day itself. If the patient is so I have patients who are on 200, 250 units of insulin, and practically on the third day of surgery, they were off insulin, they are off on medication. So at this point of time, they have been now more than 2 years post the surgery, they are particularly not taking any medications for their diabetes. The diabetes is reversed because the insulin resistance, which happens because of obesity, it is not dependent on the weight loss. The fact that on the second, third day of surgery, the sugars normalize is because of the normal hormonal changes which happens inside the body. So all the GLP-1, PYY, these hormones which were dormant for a lot of time, they get channelized, and that's how the sugars get controlled and the insulin resistance come down. So that's how obesity can cause diabetes, and bariatric surgery can reverse diabetes also. So, like I said before, lower blood pressure, lower cholesterol, there is relief of sleep apnea. There's good amount of reflux which is there, but that decreases after doing a Roux-en-Y gastric bypass. There is decreased joint pain, increased mobility. Most important is the patients, when they are low on their confidence because of the weight, the self-esteem increases and they are more active and more cheerful. There's a different lifestyle these patients have after losing that much of excess weight. And that's how bariatric surgery helps all these patients. So I can go on and on and on, but in view of the constriction of the times, I would take any questions if anybody has any questions.
Sure. So at the end of the session, I think we will
Sure,
take
sure.
up questions, but
Correct.
really appreciate you sharing so many details in such a short time with us, Dr. Salvi. We will actually quickly move on to our next speaker, and of course, we will come back to you with questions.
100%. Thanks.
Yes. Uh, Obesity can actually have an impact on our gut health greatly, and obesity is associated with an increased risk of several gastrointestinal disorders, which in turn can worsen the obesity related complications and, of course, then impact our overall well being. Fatty liver, pancreatitis, reflux, GI cancers, these are really well known these days. Our next expert, Dr. Mukta Bapat, is going to give us a deeper understanding of the obesity and the gut connection. Dr. Mukta Bapat is MD, DM gastroenterology. She has been an associate professor at the coveted KEM Hospital. Currently, she's practicing at Jupiter Hospital, Thane, and has contributed to various books, original articles, and has been speakers at various conferences, TV, and radio programs. So, really, over to you, Dr. Mukta Bapet.
Thank you, Rajeshri, and good morning to everybody. And thanks for a very kind invite. Prashant has described in detail, so I will not go into the basic details of obesity. Okay, so why are we discussing this? Is because obesity has become a universal health issue, and India is on a very high rise for obesity prevalence. And if we understand, there is no difference between urban and rural or adult and children. I think pediatric obesity has become a big issue now. Also, rich and poor both will have obesity as an issue. I think some speakers may touch upon this, that Indian have a very unique phenotype, such as thin people who still have, fat distribution issues. So as Prashant said, it's a chronic, progressive, multifactorial disease. And what we lack currently in India is that though there are very good guidelines which are at par with the international standard, is poor understanding as far as even the medical and paramedical staff are concerned, the community is concerned, suboptimal assessment and cultural diversity in India. I mean, we have different notions about...
Are you trying to share the slide?
Yeah, I'm sharing the slide. Can't you see it?
No, the folder has been seeing, not the slides.
It shows my screen share.
It does show a screen share.
I'll try again.
Yes.
Is it seen now?
No, not yet.
1 second. One second.
No problem. Just double click on the slides when you once you hit the share screen button. Yeah, you can double click on it.
It's seen now?
No.
Yeah?
No, we can't see it. I think if you can just escape and share your screen and then hit the screen button so that
Yeah, can I help? Bapat madam, what you can do is you can close this window. Your screen must already be playing on a, so close this window and you see the presentation must be playing somewhere.
Okay. So now
is the
I start
presentation
again.
open?
So when you share your screen, you see the presentation which is playing, you click on that.
No. Ma'am, first open your presentation. Just stop sharing the screen, open your presentation.
Stop sharing.
Open the presentation and then share screen.
It's open actually. I'll open it again. Just a minute. Give me a minute.
Yeah,
I'm really sorry.
Sure. No problem.
Yeah, now it's open.
Sure. Now share screen and double click on the slides.
I can't go to Zoom now. 1 second.
To go to Zoom, just escape.
Not able to join Zoom.
You're on Zoom. So just escape the screen. Just hit your escape button and you will be able to see them. Your Zoom is minimized, that's all.
Yeah?
No, we still can't see this.
Let me try.
Yeah.
Is it okay now?
Yes, perfect. We can see this slide.
Yeah?
Yeah.
Okay. So, is that okay now? That's running?
Yes.
Okay. So I think we have already covered this, because obesity being a universal issue and we really need to see the impact. And as you have mentioned, Rajeshri, it does impact on all the systems. And I will be specifically stressing upon the gastrointestinal involvement of the chronic disorders and some critical issues about that. So, obesity is, though it is universal, we need to know who becomes obese. So, they are in genetically predisposed people who have unhealthy lifestyles and unhealthy diet. Some interaction between the gut microflora and the interaction between the systems, endocrine system, the brain, you finally land up having overweight or obesity. So coming to obesity and this is a busy slide. I'm sure either Dr. Patankar or Dr. Pahuja would stress upon this. So the audience can see that there is a lot of interaction between the brainstem, hypothalamus, the hormones, the actual adipose tissue, which secretes certain abnormal hormones or substances, and they go on to have a lot of hormone secretions from pancreas, from the intestinal bacterial flora acting on it, the ghrelin that Prashant touched upon, which is in the fundus. That's how you land up with obesity and having multifactorial involvement or multi-system involvement. Now, as far as intestinal system is concerned, if you can see, every organ in the intestinal system is involved. Like if you see esophagus, that's a food pipe. You would have more prevalence of reflux disease. More acid would come into esophagus, would lead to erosive esophagitis, can go on to develop Barrett's esophagus, that is change in the lining, can predispose you to have esophageal cancer. Stomach, again, same. You can have more erosions in the stomach and can lead to gastric cancers in future. Liver is the most important organ that is hit by the obesity. We have a separate slide on that. So these patients would land up having fatty liver disease, can go on to develop cirrhosis, and the most dreadful disease of hepatocellular cancer. In fact, patients don't understand that they have hepatitis. They just come with a fatty liver on ultrasound, and a couple of years down the line, they will come with fluid in the abdomen, bleed from varices, or directly hepatocellular carcinoma. Obese patients are also prone to have constipation, diverticular disease, and colorectal cancers. They will also have some abnormality in their small intestine and the large intestine and come with a lot of dysmotility issues like gas bloat and constipation. Let's see how it happens. So you have more increased abdominal pressure that leads to decreased pressure in the esophagus and stomach junction. That would make you more prone to develop burps, would develop more prone to develop reflux disease, and you will have reflux disease, gastroesophageal reflux disease. It is thought that certain pro-tumoral factors are released by this visceral fat that makes you prone to develop GI cancers. As I said, there is a lot of interaction between the diet, the gut bacteria, the hormones, and some other substances which can go on to have decreased motility of intestine, increased motility of intestine, enhanced gastrocolic reflux. They can secrete certain substances or can diminish certain substances which are responsible for intestinal health and immunity as such, and can make you prone to develop either functional bowel disorders, or they can make you prone to develop inflammatory bowel disease or pancreatitis and fatty liver disease. So that is the scope of obesity. Coming to obesity and liver, if you all can see this picture, so fatty liver is very common in obese people or even overweight people. Fat actually goes and deposits into the liver. You will never know that this is happening unless ultrasound picks it up. Subsequently, it will go on to develop a fatty liver disease and will develop cirrhosis, if you all can see. And the dreadful thing is hepatocellular cancer. And it's not unknown, it's not less. In fact, it is one of the, I think it is a top leading cause of cirrhosis nowadays, even hepatocellular carcinomas also. And they're very amenable to treat, so that's the best part about it. So this is again a short, I'm sure some other panelists would touch upon this, the insulin resistance that Prashant talked about, hyperinsulinemia, hyperglycemia, how the healthy liver actually turns into fatty liver and the fat and actual developing hepatitis and then developing cirrhosis. This is a nice slide I found. We have a lot of bacteria from mouth and from anal canal. They do a lot of good to us. Everybody knows good bacteria and bad bacteria. So the most important thing that they have is short chain fatty acids, I believe. And they maintain the gut immunity and gut integrity. Lack of them will make us prone to develop a lot of inflammatory conditions, and maybe more infections. Because of dysmotility, we can have more burpers, bloaters, constipation, having diverticular disease, and also IBS symptoms because they have either lactose intolerance or they may not tolerate certain other substances which are gasogenic. So this is where probably nutrition will have a lot of role to play. Changing the bacteria, helping to change the intestinal barrier into a healthy barrier, and then changing the metabolic outcomes in these obese individuals so that we can decrease the insulin resistance, decrease the triglycerides. The exercise can help to get fat down and subsequently get these people out of their mental or psychological symptoms. This is another busy slide. Just I want you all to understand that how obesity can affect inflammatory bowel disease, irritable bowel syndrome, celiac disease, reflux, pancreatitis, and liver disease, of which liver disease and inflammatory bowel disease are critical health issues. The rest all are chronic diseases, which can be taken care as patients keep coming to the OPD. But liver disease and inflammatory bowel disease need very specific attention. I've got 2 slides on that. So anybody who is overweight and who is found to have liver disease really needs to be very careful about his follow-up with the doctors. Apart from hepatologists or liver specialists, they do need nutritionists to take care of their weight loss, take care of their nutrition, take care of their protein intake and protein supplements as omega-3 fatty acids, or how exactly they can go about the diet using Indian diet, not very fancy diet definitely. So these are patients with inflammatory bowel disease. They also can undergo bariatric surgeries if needed. They are on immunosuppressants, so they will be prone to develop a lot of inflammatory conditions or infections rather. They also need to take care of their sarcopenia, and protein intake should be monitored. So another important area for nutrition here. And when they are on steroids or immunosuppressants, one needs a specific sort of attention to their calcium and their vitamin deficiencies. They really need special address. So this is, I think, second last slide. So I would like to end here by saying that obesity is a very, very genuine and important problem, and a lot of insight is required for that. Any doctor who sees, maybe he's a physician, he's a family physician, he's a surgeon or a gastroenterologist, or even a nutritionist for that matter, a thorough assessment is required to rule out any endocrine cause or any other treatable cause. All systems should be carefully evaluated because we have a lot of cardiovascular, pulmonary implications, and they are responsible for high death rate. This cannot be underrated at any time. We must also look for development of malignancies. Diet, exercise, and medicines. I think the subsequent lectures would concentrate on that. They have a crucial role in management of these people. We must avoid any extra unnecessary, unindicated options for weight control. We should use natural resources, but when it is required, we should turn to right medicines and surgery, as Dr. Salvi suggested in his talk. So that's my last slide. A very vigilant approach for obesity, a proper assessment, right pharmacotherapeutics, motivation to these people. As a community, we should know that there should be no body shaming. There should be no fun made of these people. It is extremely important. I mean, it goes a long way for making them a healthy inclusion in the society. Prevent any comorbidities and help them to have a better disease-free or a disease-controlled life. Obesity is not a choice, but it's lack of your options. And even if we get it in genetics, we have our lifestyle to manage how we can overcome it. Thank you. Thanks, Rajeshri. Thanks again for allowing me to be here to share the slides. Thank you.
Great. Thank you so much for so many insights in basically gut health, because we all know, and suddenly we see so much of noise around fatty liver, of course, and cancers and much more now. So your role is actually getting more and more important in managing obesity, really. Having said that, we will, of course, have some questions for you at the end of the session. But we'll move forward with our next speaker, Dr. Vimal Pahuja. Comprehensive multidisciplinary care, including holistic assessment of patients' history, personalized treatment planning, including nutrition, physical activity, and lifestyle management, is vital. But understanding obesity as a disease from diverse angles is actually the crux. Our next speaker, Dr. Vimal Pahuja, will be taking us through this complex topic in a simpler way with a scientific approach. We're really looking forward to this. He's currently practicing consultant and in charge of the metabolic department at Dr. L.H. Hiranandani Hospital, Mumbai. He has 3 decades of experience in metabolic diseases with MD in internal medicine. He's trained in internal medicine in the US and diabetology from UK. He's a SCOPE certified obesity physician, faculty for fellowship in obesity, body metabolism and nutrition, and fellowship in diabetes by MUHS at the Dr. L.H. Hiranandani Hospital. He is a member of the Obesity Task Force, Maharashtra State, and has been speaker and organizer at many national and international conferences. So over to you, Dr. Vimal Pahuja. We are really looking forward to your insights.
Thank you so much. I hope my slides are seen.
Yes.
Yes, a little bit of hurry because I have to leave. So, well, everybody has spoken a lot about the treatments of obesity, what are the derangements. But the point in case is, are we ready to talk about obesity, and whether the audience who's listening to you today understands the obesity is a disease, whether they agree that obesity is in the same in heart disease or diabetes. Unfortunately, no. Nobody understands that obesity is a disease still. There are a lot of bridge gap which is there between the provider and the doctor. Doctor is speaking some different language. He's speaking from the health point of view. Patients still, or the public still doesn't understand that obesity has concerns. It's not only the weight. So unfortunately, the weight has become synonymous with obesity, which is not true. We have to understand that obesity is a perfect and complete disease in itself, and this is the thought we need to percolate in the society with this medium. That is the most important job I think we have to do today, and that's what I'm going to talk about today. Is obesity is a disease, but we identify that obesity is a disease. It's a disease which is masquerading in such a way that doesn't appear one. You see it, but you don't see it. No, it's in front of you, but nobody recognizes it's a disease. It's disease which leads to other diseases. So it's one disease, but it leads to so many other diseases. Speakers have pointed out about so many things which can come because of obesity, and I'm also going to touch upon those. Then, if you see, this has a complete dimension which is percolating in the society and in our socio-cultural setup. So it is very difficult to differentiate whether we are dealing with a weight, obesity, what it is. It is a social issue, it's a cultural issue, it's a medical issue, and that's the reason it is difficult to say that obesity is a disease, what it is, and there's a confusion about in the public about the same. It is a disease with limited treatment option. We know that the options are limited now, but of course now we are expanding the horizons. We are getting a lot of other options, and that's why what has happened, the public has been left longing for definitive treatments. These are my viewpoints, absolutely. So they see the onus is on them only to treat, and that's why you can see a lot of people treating their own self, losing weight, doing something, experimenting with the diets. And that's the reason we have to give the clear message from this medium that obesity is a disease to be treated by an expert. Okay, self-experimentation can be a wrong thing sometimes, and people can have a lot of trouble because of that. Where there's a perception difference, that's why I'm saying, between the public and provider, why there's a perception difference, why you think that people don't think differently from the doctor. Hum khud kar lenge, humko pata hai. Obesity is a health risk. Focusing on treating the disease may overlook the mental aspects. This is the provider's outlook. They only see this as a health risk, yes, because we think of course it is a health risk. We have to focus on treating the disease, but what does the patients think? They think from the social point of view, shadi hai, kya hai, weight utarna hai, body image issue. Focus on the weight, not on the health. So we're looking at again the same. The weight has become synonymous with everything. That point of view has to be erased or has to be changed. Not on health. Resort to quick fixes. That's why they want to resort to quick fixes, because the medical treatment will take time. Or we don't know. They have to give 3 or 4 months, but they want a quick fix because I have 2 months. I have to get married. 1 month I have to do this. I have to get pregnant. Could have to quick fixes, and that's why they fall to They are gullible for the quickery. And this is what my message to the entire audience, that please understand that there are no quick fixes in this. If you're doing some quick fix, it's going to come back and hit you hard again. World is getting fatter. This is a recent article published in the Lancet, 29th February, which shows that how fat we have become. See the India here, green. Actually, hardly any prevalence of obesity. And look at today, 2022. This has become yellow. It is around 30%, 20 to 30% prevalence. So you can see overall there's an increase in the obesity world over. And that's something which is alarming for us. And of course, if by 2040 we will have 2 times more overweight people now we have today, 3 times more obese people, and 33% of the women who are in the reproductive age group will be obese, which is a very bad news for us, because these obese women will lead to the progeny which are obese and diabetic, and this whole world is going to become diabetic slowly if you are continue like this. And now in India, what you're seeing, urban and rural, nobody's no area is spared. India is also getting fatter. In all age groups, you can see urban residencies or rural residencies, any age group you look at, National Family Health Survey, we are getting more and more obese. 33% in urban areas, 19.7% in rural areas. So rural areas are not spared. If you think that rural is गांव में सब ठीक है, नहीं है, ये बहुत खराब होने वाला है. So are we getting an evolution? Something is going wrong in our evolution. What we are doing with us? We are saying technology, we are superior, we have got AIs and whatnot, but is the evolution going in some wrong way? We are becoming Homo obesian and Homo diabetians. We are Homo sapiens. We were evolved as Homo sapiens, but what we are becoming as Homo obesian and Homo diabetian. Now that you have everything, but your health is going to be a challenge in the next. So that will be a bigger challenge than anything. In fact, nuclear war as well. That's going to be a bigger challenge, and that was we have to look at that. How we change our perspective now will define how we are going to go into evolution next few hundred years. So there are very important causes of obesity. Of course, addiction, cognition means you have food is addiction. So how you perceive this, how you remove this addiction from your mental, the mind, that is very important. The genetics and epigenetics are very important causes. So genetics is there, genes are there, but the changes which are happening because of the day-to-day environmental influences is also very important. So those influences have to be negated. Some people may not be having genetic influence. They don't have genes, but they still are obese. These are epigenetic changes. Because of the wholesome environmental influences throughout the journey of life. Nutrition, hormones are very important. Exercise and activity levels, of course, sedentary lifestyle is one. Sleep is very important. Stress, immunity, all are important. So these are multifactorial causes. Multiple factors are influencing the obesity. It's not one factor. And of course, then overall influences how is the workplace and how is the stress, how is the community and lifestyle in the community, whether you have sufficient places to walk, do exercise, so on and so forth. What is your food policy? Are you getting a फूड प्रोक्योरमेंट इज सच अ प्रॉब्लम. आप किसको बोलोगे डाइट करो, नहीं कर सकते सर, खाना मिलता नहीं है, हेल्दी खाना मिलता नहीं है. वी सर्व ओनली वड़ा पाव, वी सर्व ओनली डोसा, दिस इज ओनली सर्व्ड इन अ कैंटीन. Food procurement is such a problem. What we're talking about, taking out obesity, procurement of a proper and healthy food is a problem. Healthcare and policy delivery is also very important. Financing, funding, all these things. We have to think positively and to look at some very measures, concrete measures to take out these problems, to eliminate those factors slowly. Otherwise, it is going to be a problem for everybody. So obesity is a mother of all disease. Dr. Prashant Sal, we are told, but there are many diseases. You name from head to toe, there are so many diseases which are caused by obesity. So I think this is enough to say that obesity is a disease itself. Look at yourself. Look, if you are having particular BMI more than 25 kilogram per meter square, or waist circumference more than 90 centimeters for Indian males and 80 centimeters for Indian females, is enough to qualify you as obese. Thus, of course, you can say BMI may be a fallacious. It can be a problem. That is the simplest tool. That's why we define with BMI. But if you can do a body composition and say your body fat percentage is more than 25% or 30% for females, it is obesity, and you should start doing something about it. What you should do is the question now. Should I do an exercise, or should I diet, or should I take a medication and directly go for surgery? There are stages what you have supposed to do, and we define those stages depending on how many problems you have with obesity. You have diabetes, you have blood pressure, you should do fast. Now there's no time. If you don't have any complication as yet, you are still free of any problems, mental problems, or you don't have any mechanical problems, you don't have back pains and nothing, you still have time. You can give yourself time for diet and exercise. Surgery will be indicated. There's a particular time when there are multiple complications not getting into relieved by all the modalities. Then you should think about surgery. But we'll come to that one by one. So when you're talking about obesity treatment, you have to address the root cause of obesity. It should be evidence based and it should be holistic. It should not be one treatment. Diet kar rahe hain bas. That's not going to work. You have to close all the loopholes. Stress, sleep. I will show you all those things. Multidisciplinary approach. And we are having a curated program which is called Hira program. We give 800 calorie diet, as Dr. Salvi was saying, but patient will not feel that they are starving. The diets are curated in such a way that they feel satiated throughout. With 800 calories, 850 calories, they feel that they have full, and they are able to exercise, be active, complete 10,000 steps, work in a gym, and they are able to do everything which is required by a human to work, progress, productive level increases, they feel energetic. So with proper diets, with proper thought, thought plan of exercises, you can actually deliver good results. There are a lot of things which we can do in there. We have not actually explored what they mean. People say diet and exercise. What it means diet and exercise? It should be a structured program. It should not be just at random. Something diet, some exercise. No, it should be a structured program. Only after the structured program fails, pharmacotherapy fails, then you should think about surgery. Personalized and targeted. Every treatment has to be personalized. No one shirt will fit all. That is very, very important message. It has to be personalized and targeted, and that will be decided by an expert. And it should promise realistic expectation. You should expect something unusual out of the treatment. You should promise that this is what I am going to deliver. So that should be very upfront and it should be very clear and transparent. So obesity treatment, then it will be successful. So science of weight loss is so simple that if you eat less and move more, it's going to give you weight loss and you will be able to maintain that weight. Not so simple, because brain is there to take care of that. Hormones is going to balance your energy intake and output. Whatever you do is going to actually resist weight loss. Weight is the only thing which is going to go up evolution wise, and brain is the only thing. Brain is going to wire in such a way that is going to stop you from weight loss, and that's why it is very difficult. It's not that simple always to lose weight, because there is something physiology which is there. It's not always physics which is coming into play. There's a physiology which is coming into play, and those are hormones which are going to counter those efforts which you are doing. That's why we have to, throughout the life, there's a battle of forces which is going to come. Healthy diet, physical activity, sleep, stress reductions, eating patterns, weight stabilizing, all have to be there. You have to do everything. Sleep acha hona chahiye. You should have proper diet, exercise, ideal lifestyle, what we say. But it's very difficult, ideal lifestyle. So how do you juggle? That is what most important. How do you make patient juggle in the ideal lifestyle in this world which is very fast? And that's the challenge in which we are trying to help out patients in our program. So abnormal dietary constituents and healthy muscle. Muscle is very, very important. I touched upon muscle. Muscle, people forget. When they lose weight, they will lose muscle. Anything, bariatric surgery, medications, everything will cause a muscle loss. There will be some muscle loss, maybe 10%, 20%, will be some muscle loss. People are doing diets on their own. They are not looking at the protein. They are losing a lot of muscle. Believe me, muscle is the only thing which is going to protect you long term for weight maintenance and for your fractures and falls. As you grow old, if you lose muscle with all these things, you have prone for fractures and falls as well. Muscle is very important. Preserve the muscle, and that's why body composition, looking at not only weight but composition. What I'm losing muscle or losing fat. That becomes very important. That's why it should be a periodic screening for that, and muscle mass has to be preserved. There we screen the muscle. There's some dynamometer. You can look at the sarcopenia, look at the muscle loss, try to increase the protein and exercise. And strength training becomes very important. Dr. Tapatankar is going to touch upon diet, exercise in a very elaborate way. I'm not going to touch upon that. He's an expert in that, but just saying that protein, weight strengthening is also very important. You have all the options. Medications are very, very important. Behavioral, of course, counseling, stress eating, a lot of things are there. We discuss all those things. Behavioral therapy. Mind also becomes important. People don't recognize that I may be stress eating or I may be emotionally eating, and mind has nothing to do with obesity. 100%. Everything is located in the mind. Mind, obesity is in the mind, what we say. So you have to treat your mind first. You should be motivated. You should be very positive about your weight loss. Then only you will have a weight loss. If you have emotional stress, depression, anxiety, that should be treated first. And then you should move ahead with the journey of weight loss. Calorie deficit, physical activity, yes, those are important. Pharmacology is very, very important because this is a disease which we say. For heart disease, you take medicine. For blood pressure, you take a pill. Don't shy away to take a pill. Then why are you shy away taking a pill for obesity? It's a disease, and so this pill will help you to reduce that problems which are going to come because of obesity. Side effects are with anything and everything in the earth. Side effects are going to be there with everything. We are upfront with the effects of the drug and side effects of the drug. They are not very notorious side effects. The drug, right? We juggle with the side effects, and if you don't tolerate, we stop it. But at least we should give the drug so that you should be able to get out of the obesity, conundrum. You will be able to, otherwise in the you'll be in the maze of obesity, and you will be keep going square one. The law your weight yoing people keep coming 5 kilo loss, then 5 kilo, 10 kilo gain. This is thing. In fact, bariatric surgery also. After bariatric surgery, we have used medication. People who are not able to lose weight, we have used medicines and they lost weight. So bariatric surgery, post-bariatric surgery also, medicines are important. So surgery, of course, then you have balloons, and then you have surgeries. All modalities of treatment, depending on the situation and comorbidities, we decide. Now you can see the surgeries, bariatric surgery, 30% weight loss, but medicines are able to breach that mark. New medicines are coming. New obesity medicines are becoming safer, better, and they are going to breach that mark of bariatric surgery. 25% weight loss with a new drug, semaglutide. Now new drug, there's a one new more drug which is there, retatrutide. 25 to 30% weight loss will be seen with those drugs. So you can see we are breaching that mark of bariatric surgery with alpha medicine. So medicines are be there because it's a disease. Diet, exercise should be the base. Of course, every therapy, diet and exercise, and it should be structured. It should not be unstructured. It should be there, but then you should have also medications with this. So thank you so much for your little small elaborate presentation from my side. Questions, I think Dr. Patankar will answer from my behalf because I have to exit today for some important event. Thank you so much for inviting me here, Dr. Rajeshri and True Health, and look forward to seeing you in some other meeting. Thank you.
Sure. Thank you so much, Dr. Pauja, for taking out time and sharing your insights. And we're really happy that you are working on a very focused program, which will help people really lose weight when it's so very difficult. And as we know that this disease is getting more and more alarming. I'm sure you will join us on more sessions we will be conducting on obesity in the
Sure.
future.
Thank you so much.
Thank you so much, sir. With that, we come to our next speaker for today. He's a prolific speaker and one of the earliest obesity physicians in our country. When we would normally wonder what is an obesity physician, he was already one, and he was already guiding his patients how to manage weight. Uh, Most of us really know him very well, Dr. Nitin Patankar. He will actually be covering the holistic approach in treating obesity and emphasizing on the physical activity aspects when it comes to yoga and also alternative support therapies, which could actually holistically help manage this disease. So I don't really, I'm going to take the proud privilege again to introduce him and then really over to him. He's MBBS, MD, General Medicine and Community Medicine. He's more than 30 years of experience, close to 40 years of experience in this field, trained in lifestyle disease management from John Hopkins University, Baltimore, and Duke's University, Durham, North Carolina, again, US. He's consultant diabetes management with diabetes reversal, obesity management, metabolic diseases reversal at Jupiter Hospital, Thane. He's director at Wisdom Diabetes and Yoga Clinic, consultant metabolic physician at the Dr. L.H. Hiranandani Hospital, Mumbai. So over to you, really, Dr. Nitin Patankar. We're looking forward to hear from you.
Thank you, Rajeshri. Thank you so much. Again, I will take a few minutes to share the screen.
Yes.
I hope it is visible.
Yes.
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 So lucky that otherwise, if technology always takes more time than the lecture. So luckily it has prop up. So today I'm going to talk on the role of ancillary therapy in obesity as in my experience. So as Dr. Vimal was mentioning and Rajeshri also mentioned that I will be very quick in mentioning about diet and exercise because I want to talk something more than diet and exercise. So in diets, they have seen that there are plethora of diets, like starting from keto diet, intermittent fasting, zone diets to General Motors diet. And I was searching on the net, there are around 200 different types of diets are available. And every diet is successful. In India, we have seen eating every 2 hourly and eating only twice a day. These are the two diets were there. But there is a big meta-analysis was presented that you follow any kind of a diet as long as you are maintaining calorie restriction, the diet is equally successful. So whether you choose, so it's basically going to a shop and having a like shopping. What diet would you like to do? And if you do it diligently, the problem is that people don't do it for a longer period of time. That is a big problem. So you do any diet, the diet will work for you. Second thing I want to mention is it has been seen that when you lose weight intentionally, you get around 34% reduction in mortality and morbidity. If you don't lose weight and remain obese, then there's a 24% rise in mortality and morbidity. But the paper says that if you keep on trying to lose weight without even losing weight, you get around 22% reduction in mortality and morbidity. So that is the crux of the matter, that if you are obese, as Dr. Vimal mentioned, that the brain comes into picture, it creates a set point and it creates a lot of problems. But if you keep on attempting to lose weight, it also gives reduction in mortality. And third thing I want to talk, I will just finish it off about physical activity. There are two kinds. First is aerobic activity, where your heart rate is raised, and that is to be done around 300 minutes per week. And it can be moderate intensity to high intensity exercises. Anybody is interested, you can read a book on something called the Body by Science. It mentions that if you work around 30 seconds exercise, 30 seconds exercise, 2 minutes gap, 4 times, that is around 2 minutes of exercise, 5 days a week. That also gives all the benefit of aerobic exercise. So exercise has got wide variety, but we have to do strength training also. So there is strength training, flexibility training that I'm going to talk about in yoga, and aerobic activity. But the most important part of any activity is if you lose weight and you don't lose the waist circumference, the weight is bound to come up. So this is a study that we are going to publish, that every kg of weight loss, if you can have 1.1 centimeter of abdominal girth reduction, then your chances of weight maintenance are very high. And if you don't lose that much amount of waist circumference, weight will come up. So I will come back to my lecture, that is ancillary therapy, which is a supportive therapy and which is useful in type 2 diabetes, dyslipidemia, non-alcoholic fatty liver disease, metabolic syndrome, hypertension, and certain cancers. And what therapies I use? Basically, I use yoga-based something called the rainbow diets, which I want to elaborate. Then I use sound, vibration, binaural beat, and music therapy, and acupuncture. So these are the 4 things that I use as an ancillary treatment, and I will like to highlight on those points. So I'm going to skip all those slides because this is a lecture I had prepared. So to prove that there are studies which are available which say that yoga works for obesity management, diabetes management, insulin resistance, a lot of conditions which can be controlled by regular practice of yoga. So I'm going to skip those slides, which I am just going to present the evidence, because I assume that the audience will accept that whenever we are talking, the evidence is present. So I'll come back to this. So this is a concept typically in yoga called as chakras. So they are like root chakra, sacral chakra to crown chakra, and each chakra is given a color. So when I started learning about these chakras, a lot of my friends were criticizing me that, okay, these colors and these chakras are all like imaginations. But in 2012, Dr. Candon Spurt was a neuroscientist who proved that exactly on the spots where the yoga describes chakras, there are receptor densities which can attract and which can respond to emotional molecules on spinal cord. So that she called as nodes of emotions on spinal cord, and that is chakra. And still, in recent times, we never knew why the chakras were given the colors. So the root chakra is of red color, then sacral chakra is of orange color, the upper abdomen, that is the Manipur chakra or solar chakra, is of yellow color. So I want to elaborate on that and how it is useful in planning diets. So this is a root chakra, and yoga books describe it is related to bones, bone minerals, bone marrow, and everything related to bones and immunity and inflammation, which is controlled by Muladhara chakra, and chakra is of red color. Now look at this. This is a 2019 article published in Journal of Nutrition and Metabolism, and it says that if you eat red color foods, it is anti-inflammatory, general antioxidant activity, and immune modulation. And then they're given like anthocyanins, carotenoids, L-gallic acid, L-gatins. There are so many substances which are like red colored, and they are linked to that. But still, root chakra may not be very evident. Go to, and these are the exercises that I use, because there are multiple asanas in yoga. Now, all asanas are not for everyone. So suppose you have problems of bones and problems of immunity and problems of inflammation, which is common in yoga, then these are the asanas which are advised. And there are something kriyas or pranayam. So what we call it Kegel Kapalbhati or lower Kapalbhati, where you are exerting the expiration pressure by contracting the pelvic floor. So that is called as the lower Kapalbhati, and that is very useful in problems with root chakra. Then let us come to sacral chakra. What is described in yoga textbooks? So it says that it is related to ovaries, gonads, salt, and kidney. So imagine Swadhisthana chakra or sacral chakra, and color is given as orange. Now look at this. The orange color foods, again, this Journal of Nutrition says that if you can have the phytonutrients which are related to orange color, like beta carotenes, alpha carotenes, beta cryptoxanthines, bioflavonoids, they are related to antioxidant for fat tissues. So you can control oxidation activity in fat tissues. It helps in endocrine modulation and role in ovulatory and fertility processes. So orange foods, orange color, and sacral chakra. So there are various kinds of asanas basically related to PCOD, related to ovarian diseases, related to uterine diseases, and salt problems. So we give these asanas, and basically these asanas are very useful in controlling the conditions along with obesity. And then this is something called as a mid Kapalbhati, or where you are using suprapubic areas to generate the expiration pressure. Then let's come to solar chakra, which is called as the Manipur chakra, and yoga describes it is related to your stomach, liver, pancreas, and spleen. And what the color is yellow. So chakra color is described as yellow, and Journal of Nutrition says that you use yellow colors as antioxidants for enzymatic activity, gastric motility and regulation, reduce glycemic impact, role in fostering a healthy gut and microbiome. So you use more of yellow colors. And when I'm describing these colors and phytonutrients, I don't mean that your whole food should be yellow in color, but there should be more preponderance. So you select the things which are yellow in color in your diet when you're having a problems of, say, liver problems, like you have fatty liver, or you have, say, acidity, you have got GERD. So obesity will have multiple other comorbidities, and you can select the foods according to the comorbidities. Then these are the asanas which are prescribed for that. And solar chakra, this is called as the upper Kapalbhati or supraumbilical Kapalbhati. So that is used for tackling the problems with obesity and which are related to, this is called as the midsection of the body. Then coming to heart chakra is called as Anahat chakra, and it describes that it is related to heart and lung, and the color given is green. Again, look at these phytonutrients. Phytonutrients like chlorophyll, epigalactocline gallate, flavonoids, folates, glucosinoids, isoflavones, thiocyanates. So they have got antioxidant activity. They give blood vessel support, role in healthy circulation and methylation and heart health. So if you can look at these, the chakra system of asanas, chakra system of various pranayam, this is called as the heart chakra pranayam. And many people feel that the bhastrika should not be done if you have got hypertension and heart disease. But there are two kinds of bhastrikas. One is called as a slow bhastrika and one is called as a fast bhastrika. So slow bhastrika is useful for heart conditions. Then I can come to sound, binaural beats and vibration and music. So this is the gamma waves, beta waves, alpha waves that we know of brain waves. And every wave or every brain function has got linked to physical function. So if I want to go in a meditative state and visualize, I can make bodily changes easily possible. So I want to attune to something like a 8 to 12 hertz. But unfortunately, our ears can hear only about 20 hertz. So what brain capacity is, so if I have one ear is hearing a frequency of 200 hertz and other ear is hearing a frequency of 205 hertz, the resulting beat frequency is 5 hertz. So my brain gets attenuated and it gets resonated to 5 hertz frequency where I can go into easy meditative state. And this is, I want to show because this is a very new thing, that exposure to 6 hertz binaural beat on 250 hertz carrier tone for 30 minutes was utilized to study in quantitative electroencephalography. And it was shown that emotional states were evaluated by binaural mood scales and pattern recorded for 10 minutes of exposure appeared to be brain functions to a meditative state. So brain can go into meditative state very easily. And that is the beauty of music therapy. So what I do usually is I inquire with the patient what kind of a music they like. Then I can get the music from them. I can build the binaural frequencies in that music and give it as a therapy. So my prescription includes basically diet, exercise, medicines, and music with yoga postures and various kinds of pranayam. So this is a prescription I give for obesity management or diabetes management. And the last thing is neuropuncture. So I'm just going to show you neuropuncture is useful for all kinds of neuropathies, all kinds of pain management, which are related to obesity. But the beauty of the neuropuncture is in wound healing. So I just want to show, this is for the dry gangrene. This was an 80-year-old patient who was on dialysis and the wound was not healing at all. The patient has undergone 60 sessions of HBOT and posterior tibial artery and popliteal arteries were stented, but still the wound was not healing. And we started giving something called as a neuroacupuncture, which looks like acupuncture, but there are various kinds of millicurrents are produced. Then this is after 8 sittings. If you look at my right side, that is on the left side of the screen. And the last thing, this is completely healed wound in around 12 sittings. So that is the beauty of neuropuncture. So these are I use acupuncture, neuropuncture, yoga-based diet or phytonutrient diets and binaural therapies as ancillary therapies in metabolic disorders. So they amplify the benefits of regular medical treatment or surgical treatment. So I think I am in time. And thank you so much, Rajashri, for giving opportunity to present this kind of a very different things to this august audience. Thank you so much.
Well, it's always a pleasure to have you on our programs, Dr. Patankar, and every time, of course, there's a new learning from you. With that, before we get on to the questions, I'm just going to share a couple of slides because I know a lot is already spoken about nutrition and the importance of nutrition has already been emphasized. But quick share from me. I mean, it's my duty to do that. So when we talk about nutrition, when we talk about diet, we always talk about diet. So like Dr. Patankar rightly pointed out, there are so many of these fancy diets that are there, and vis-a-vis nutrition. So I really focus on nutrition, and I firmly believe, and of course there is so much data out there that it's nutrition which can actually help us in better control of diseases. So while we have calorie control, portion control, we all know a lot about it. There has to be a balance in the macronutrient distribution, which is the protein, carbohydrates, and fats, and fiber, of course, which is also a carbohydrate. But there should be, of course, an increase in protein intake. The low glycemic index carbohydrates should be consumed. Good fat should be consumed. Doesn't mean we shouldn't consume fats at all, because if there are other comorbidities like dyslipidemia, good fats are necessary, and of course for various other functions. But how we balance this is, of course, a very personalized approach. How much of protein should be increased is also a very much personalized approach when it comes to it. Eating nutrient rich foods is very important, because when you're dieting, when you're reducing the portion size, calories, at that time, consuming, of course, fruits, vegetables, whole foods, grains, lean proteins, healthy fats is very, very important, because if we don't do that, we're really going to land up with other issues like bone loss, muscle loss, hormonal concerns. Again, if the hormones are again not in tandem, that's again going to in turn aggravate the disease and also cause malnutrition. So having said that, using personalized approach at meal planning, depending on the individual's preferences, cultural background, and lifestyle factors, is of course the key. Uh, Here's what we normally follow in our practice is really going about with the holistic assessment of the individual, though normally when it comes to a nutritionist, most of this is looked at by the doctor. But here is where we integrate our approach, try to understand the entire health issue of the patient, who are then really assessing the nutritional status, habits, cuisines, and help them set their goals, because most times they come with goals saying, I want to lose 10 kgs of weight, 20 kgs of weight. We have to break it down to long term and short term goals for them, so that way it becomes achievable. Also, it doesn't create a risk for the patient. So this is what needs to be done. And of course, Dr. Pauja really emphasized on the fact that scientific evidence based work has to happen in the obesity management. And most important, which I really want to emphasize on my thing, is the counseling and regular monitoring that needs to. That's the crux again. We do everything, but give the patient everything, but at the end, if he doesn't follow and if he doesn't persistently do it, be determined about it. That's the real key again. Here's what we again do, again, emphasizing on the fact that do not just keep trying different diets from the internet. Actually go to a nutrition expert who has real deep knowledge into it, has good experience in it, and can guide you through all these aspects. Putting your 35 meals together, what should be added in your every dish, to keeping it easy for you to cook, because using ingredients which can be cost effective, which can enhance the taste. All these aspects are very important. Otherwise, the compliance suffers. So I want to emphasize the fact of compliance and counseling out here, and then eliminating foods, also including beneficial foods, because a lot of times patients are not aware as to what has to be excluded and what can really benefit them. So taking all that into consideration, helping them enhance their quality sleep, bringing down stress, making sure they are adequately hydrating and drinking enough water, fluids. All this is extremely important. So that's my 2 cents that I really wanted to forth out here before we actually jump onto questions. So there are a few questions, of course, here which have come to us, and I'm just going to read out a couple of them. One has, of course, come from Dr. Rita Patil. She's a nutritionist, a very senior nutritionist. Her question is, in view of pre-diabetes concerns increasing, so this is for Dr. Prashant Sarvi. In view of pre-diabetes concerns increasing, can bariatric surgery help with minor procedures to control symptoms?
Yeah, so Dr. Rika, this is what we have is surgical and non-surgical ways. So in non-surgical ways also we have procedures such as intragastric balloon. So if the patient's BMI is to a certain limit and the patient is pre-diabetic, cholesterol is borderline, dyslipidemia, the patient has snoring issues, has obstructive sleep apnea. So for minor weights also, we can have a temporary procedure which is called as an intragastric balloon, wherein we put in the balloon. So what we put is the world's first adjustable intragastric balloon, wherein we put the balloon and we keep it for 1 year. After 4 or 5 months, what happens? The patient starts eating again, and they feel that they can completely adopt and they can still eat the normal food. The quantity is still expanding. We again go in endoscopically. We increase the size of the balloon to make it to 750 ml, and then this further restriction happens, and then after a year's time we can definitely take out this balloon, because the balloon can be kept only for 1 year in the body, and the restriction which the body gets for 1 year, it's quite decent amount, because for 1 year if the patient restricts his food by the balloon, then there eventually the diet decreases. So this always say that 21 days example, people always say if you can do this thing for 21 days, then the habit actually forms. So for 1 year, if you have a restriction on the diet, after removal of the balloon, you can continue the restriction. But at the end moment, diet, exercise, like I always say, it is the backbone. Even after removal of the balloon, if you are having a very erratic diet, you can again get back to the weight. So diet, exercise, I would always stress upon before and after any kind of bariatric procedures.
Great. So that answers Dr. Patil's question. There's another very critical question actually coming from Dr. Rekha Bhatkande. Her question is, my persistent concern is the mental health issues, and I think any of you can take it, maybe Dr. Patankar can take it. My persistent concern is the mental health issues that are associated with obesity, both because of obesity and because of the management of obesity. What tools do we use to predict, diagnose, or prognosticate these issues?
Yeah, so basically that was the main reason why we started a program called Hira Regain in Hiranandani Hospital, where we have got two counselors to do the first assessment of the patient. And then there are a lot of behavioral changes. Then there are issues of coping with stress, family stress. And that's why the follow-up visits are kept more with counselors than with the doctors or dietitians. Because one diet written can be followed up for around 2 to 3 months. But the counselors are more important. And they have got various measuring techniques, starting from eating behavior to stress management to coping behaviors. And they use the techniques like motivational interviewing, motivational counseling. And then unless the behavioral change is precipitated, the treatment is not successful. So the counselor becomes a major part of our obesity management program. And other, I will try to elaborate on this. Like I mentioned about that slow Bhastrika. Slow Bhastrika is breathing around 6 beats per minute or 6 breaths per minute. And there are a lot of studies done on these, and that shows that it increases your parasympathetic tone and easily calms your mind. And that can give you a lot of time to think about yourself. And the counseling sessions become very useful when you are doing this slow Bhastrika. So combining these two will tackle that issue.
Yeah, thank you, Nitin. It's lovely seeing you on the screen after so many years. But actually, I'm really concerned about the medication that, all the newer drugs that are coming in for metabolic diseases, including obesity, and the serious mental health issues that they can cause, including suicidal, behavior. So,
Madam, what we do is basically you are talking about drugs like GLP-1 receptor analogs. So GLP-1 receptor analogs, we do the regular studies about pancreas and thyroid, and taking detailed family history that these kind of diseases are not present, and then these drugs are given. Again, when we start on these drugs, we ask our counselors to monitor them whether they are developing any changes. And these COX-2 inhibitors which were present, but that is now like rimonabant, which came into market, which had the suicidal tendencies. But newer drugs like GLP-1 receptor analogs or GLP-GIP-1 receptor analogs So they don't have these kind of effects, but definitely it is GLP-1 receptor analogs in very few percentage of populations, especially in Scandinavian countries, they have shown to have an increased incidence of medullary carcinoma of thyroid. So we do thyroid studies, pancreatic studies, and counseling studies, and then use these drugs. And they are really giving you like 20% to 25% weight loss. And there is no rebound phenomena that once you withdraw the drug, if the counseling is really helpful and they have attained the behavioral change, the weight is maintained also for a prolonged period of time.
Yes, thank you, Nitin.
Thank you,
So,
madam. Nice to hear from you, madam.
moving to one more question now for Dr. Mukta Papat. Basically, uh, these days there are a lot of maldigestion issue, or rather, digestion is becoming an issue because of consuming junk foods and so much of overload on the GI tract. So, does maldigestion, can it be a risk factor for obesity?
Maldigestion per se will not say as a risk factor, but then this abnormal food intake can definitely be a risk factor for obesity, which will sort of go in a long way. Maldigestion is a different concept where you don't have the enzymes to digest the food intake. I will not use the term as maldigestion, but it's an abnormal or unhealthy food intake that will go a long way for obesity.
I will like to add two things. One is we talk of junk food and then we think of Swiggy and Zomato and McDonald's and all those brands. But majority of the junk food is created in home. Because if you cannot like burn that calories, or if you cannot throw out the calories, they will be stored. And most of the people who avoid junk food, like traditional junk food, they eat food at home and they don't do any activity, they are sedentary, then that also becomes junk. And secondly, as Dr. Mukta said, that maldigestion, many times the drugs like orlistat or cetelistat, they are lipase blockers. So people take that drug, and I have seen prescriptions from few of the good doctors that they are taking orlistat. Orlistat can cause some amount of fat indigestion. And along with that, they give drugs like unienzyme or some kind of a enzymes. So on one side, they are blocking a lipase, and one side they are adding lipases, or your drug pancreas is given with orlistat. So I would like Dr. Mukta's opinion on that this dual kind of a therapy.
So I have two takes on that. Basically, one is you said about junk food at home. We must know the kind of fat that we are eating at home and outside food. So the kind of lipids that are incorporated in your burger, in your even the coffee and tea that you get, the creams that are used. So they are very unhealthy fats. Whereas maybe the ghee, what we call toop or loni, they may be a shade better kind of oils that are used. So I will not call it as a junk food. So if you are eating that, but if you are eating burgers, if you are eating samosas, if you are eating cheese, if you are eating what should I say, mayonnaise, that is bad kind of fat. I hope Rajeshri agrees on that. So
I want to add that when I say junk at home, means any food that is eaten in excess quantities can become junk.
but
So the
that's
quality of the
not
junk is different. The good
agreed.
junk and bad junk.
So you need to burn out the calories that you take. But even you eat 2 burgers and if you jog for 10, maybe 1 hour, but still the fat that you're taking is unhealthy. That is still going to work on your cardiovascular system. So the kind of food that you're eating is also equally important. Yeah, I hope I'm clear. And second is use of orlistatin. So I sometimes feel it's a shortcut, taking medicine just to avoid fat digestion and then supplementing with something. It is better that, you avoid fat, you eat right kind of fat, you eat right kind of protein. So you're taking medicine that's, I really don't think that's a even scientific way to do that. I know who can write orlistat as a prescription and then supplement it with food intake, but I'm not sure that's a healthy kind. Whereas semaglutide or, these GLP-1s are far more scientific drugs which have proven benefit if you use in right proportion and right indication. Thanks.
Sure, it's tough to actually persuade your patients to when you tell them that no, there is no medicine. You need to you need to work for it to actually lose weight. So but that's what you, like you rightly said, that's the right way forward. The other couple of more questions actually. One again, Dr. Bapat, for you is that there is of course a rise in cancers and a lot of alarming evidence or articles in the public domain these days. But is there really a rise in the cancers, and do you really see that obesity is sort of associated with it largely?
I don't have a support from India to say that we are really seeing, because if you see so many people above the age of maybe even at younger people, they will come more with cardiovascular illnesses and lung issues and liver issues more than cancers. What I can say is maybe hepatocellular carcinomas are on the rise. So these kind of cancers which are directly related to that will come, or maybe you have pancreatic cancers again, maybe because of other existing issues, maybe alcohol, overweight, diabetes. So these peculiar kind of cancers may be on rise, but not as a whole, as you say. I'm not really very sure that whether esophageal cancers are on the rise or gastric cancers are on the rise because of obesity per se. There could be other factors which are impacting that, the kind of food or the smoking or tobacco or
The colorectal ones?
The colorectal ones, again, I'm not sure. We see them a lot in even thinner individuals. I'm not sure whether it is obesity that is causing. It is proposed cause, no doubt about it. I'm not sure whether we have an Indian data to strongly, robust data to support that. If you're obese, you are more likely to have colon cancer. I still don't know. I don't have a data for that.
Okay. Thanks. I have just one question for Nitin Bhai. When he said, junk food at home, junk food, but the common usage of the word junk food is, something which has no kind of low nutritional value. It has preservatives and things. It's a packaged food. So what does it really is junk food? Something that you really store for achar or chutney, which you store for a long time and you having it regularly, or what you mean by that? Just a clarification.
So basically, sir, when I made junk, it was little to be taken on a lighter note, because
Acha, acha.
many
That's-
times the people eat, let's start eating कि बारिश चालू हो गया तो भजिया खानी है, और इतनी भजिया खाते हैं और फिर वही तेल नेक्स्ट डे भी यूज करते हैं. So you have already created some chemical changes in that oil. So what I was saying is that the junk food need not come from McDonald's only. If you are sedentary in your activity levels, then the junk food can be created at home also. And typically people bring a lot of mayonnaise, a lot of things at home, and then they prepare at home. So
I
healthy
understand.
ingredients may not be creating the food.
This is a question completely defending the family front. On the other phone, my wife is actually listening. And the moment she learns, there can be Rajeshri as auntie. So this can create a furor. I mean, obviously, I'm a metabolic physician, obviously with no attention and heat as a family member. But when your words come into play, that may take a major role to act on. So I'm thankful that you said that, and people should have clear. I had put in some questions for even my bariatric surgeon brother. We seeing this, whatever we are doing, we are failing. Finally, we are failing. I mean, as you said, brother, that drugs are doing well. Drugs are doing well in terms of durability. They are not giving you diseases as long as you are continuing the drugs. The moment you stop the drugs, 70-75% people come back saying we have put on weight, their waist circumference increases, everything comes back. So this utter failure of this recidivism coming back, whether it's our medicines, pharmacotherapy, or whether it's his surgical, is a note of big concern. And we need to do and apply motivational interviewing in a much more structured manner to all the patients whom we even start contemplating to talk about, weight loss or fat loss program.
Absolutely a perfect point, Dr. Devashree Basu. Thank you for joining us. And I think you and Dr. Rekha Bhatkande really brought out that point, and bring the motivation behind it and trying to create more support groups and motivating people to lose weight is really very important.
Rajashri,
And one more thing to the junk thing which you said is, and like you rightly pointed out, at my house at least, we don't know where the kadai is. So, it's hidden somewhere, and we don't use it at all. So there is no frying at home, no kadais at home. That's the approach you should be using.
so I want to
So
add
what
one point. Sir, what sir said about motivational counseling and everything. So I ask one simple question to all patients. What will you do after losing weight? How that lower weight will be useful to give you pleasure or to your profession or something. And I've got a lot of patients who have joined the adventure sports. After losing weight, they are maintaining weight very well. So if you lose weight and that lower weight is useful to you in your day-to-day life, then only the chances that patient maintaining weight are very high. Otherwise, some patients who are themselves doctors and counselors, they have said that the journey of weight loss was more beautiful than actually attaining weight loss. So it gives a kick that you are doing something, you are doing diet, you are doing exercises, then you change the diet and say there is a variety. And that's why if the lower weight is not useful in your life, then it's usually you get regain of the weight. So all counseling and everything, but ultimately like WHO has said once that the health cannot be a goal. Using health to attain life goals can maintain your health. Otherwise, it is not useful.
No, and also what I want to put in a point here is like with endocrinologists or the diabetologists, they come into picture, and when we all sit together as surgeons and diabetologists, they always say that medicines are going to do the magic. It's not like that. It's always a combined approach which should be individualized for a patient. Medicines, surgeries, again, medicines, everything has to be in sync. It is not just the pediatric surgeons are the king or the medicines are going to be the king. It is not like that. Everybody has to work in sync. Medicines can be given to patients who have undergone surgery and they have come with weight gain. Here we try to understand that obesity is a chronic, progressive, and incurable disease. How much ever we say that the patient will lose weight, the patient could maintain the diet and exercise, 2 years down the line, after the surgery, patients can go haywire, they can come with weight gain. That is the point where we can again put in medications, give them that desired weight loss, and try to maintain it. Only with the medication. See, what happens is we should not be talking about failure about the treatment, even with exercise, diet, or even with surgery. When a patient of diabetes starts with oral hypoglycemic drugs, insulin comes into practice when the sugars are not controlled. We don't say that the medicines are a failure. We are trying to treat something.
Brother,
Obesity, diabetes.
I would interject.
Yeah.
We do make a point and say this is a case of primary OHA or a secondary. We normally say secondary OHA failure,
Right.
and we
Right.
that work so stubbornly that it gives a negative connotation to the patient's mind as well as much more to my mind that I have failed as a doctor. As a surgeon, you will not maybe. Obviously, you also realize the person who really reduced weight was looking absolutely prim and proper, comes back with that kind of same old look on
Right.
the on the bed. And what
Right.
I say is that the set point theory, settling that set point theory is not your and my job, a cup of tea. It has to be
Perfect.
very strongly, be clubbed with our girls like Rajashri and the bench. So this is a time that we should actually raise that cadre more than highlighting us, and we should ask the person or the patient and the family members to keep in constant touch with that bench of people whom we call educators. So this is something that we all are like physicists, we all, you and I, and Nitin Bhai and Aditi, all we are failing because we are not garnering that bench of people. I'm not talking individual, I'm talking about the country as a whole. The government should now make more educators than doctors. It's time that they have, people have pampered us. We have been rather, well pampered. And it's time that we really raise this bench of people, beautiful girls who can actually take it forward.
And also, what I would say is obesity should be talked about more. If a physician is seeing a patient for, let's say, diabetes or maybe some kind of health issues regarding an orthopedist seeing a patient for knee pain, but if obesity is there, it should be talked about. I mean, we are not.
Wouldn't agree more. Even a common cold, a gastroenteritis, everywhere that brought into alarm. Yes, of course.
Right.
Rajesh, if I may, Prashant, Devashish, both of y'all have spoken about how the public should be made aware. Another thing is the government should be involved. I must tell you something that the government of the state of Maharashtra, they have actually banned high fatty, sugar, salt foods to be allowed to be kept in eatables to be kept in the canteens of schools and colleges. I think it's a very positive step that they've taken. Uh, whether it's actually being implemented across every school and college is a debatable point. But the Maharashtra state has actually come out with this because they wanted to tackle this whole childhood obesity problem. So I think we
No,
need to. I mean, if they
this
don't
is
call it junk
an
food; they
eye-opener.
call it high.
This is an
Yeah.
eye-opener.
I'm going to interject before you speak. I just want to quickly introduce Dr. Rekha Bhatkande as Dean with Shushrusha
I'm
Hospital
sorry,
at Dadar in Mumbai.
my Rajesh, I'm sorry, my thing is a little unstable. That's why my
No
video is
issue.
not on. Yeah.
That's okay. So she's and that's and she's a very senior gastroenterologist. So I think her inputs are very valid. And madam, that sort of takes us to all the inputs out here that all of you are presenting is taking this as a public health issue and taking it really forward very regularly as Dr. Prashant also pointed out. So I think we should the effort is going to go in that direction, of course. I think Dr. Patel.
Yeah, I wanted to say that this year's World Obesity Day theme is let's talk about obesity. And so what these people are saying, even in cold and fever or maybe orthopedic problems or any problems, let's talk about obesity. And because people are shy of talking obesity, because
Yes.
many times when we talk of patients and patients' relatives are obese, and we say that this is basically maybe a familiar problem or a cultural problem of obesity, they say हम तो खाते पीते घर के लोग हैं.
Yes.
So one person having severe problem you treat, otherwise why you want to interfere into anybody else? So let us talk about obesity in all fronts. That is the theme of this year's World Obesity Day.
So one more point, I think, Dr. Bapat, quickly, before I go to you, my colleague, of course, rightly pointed out that eat right is something which the government is also taking up into hospitals, and we are already implementing something like that at one of the hospitals here in Thane, trying to design a menu itself when patients are admitted at the hospitals or whenever they are there, so they get an idea as to what ideal healthy diets can be, and also educating the entire system in the hospitals to
Come to Shushusha, Rajeshri. Come to Shushusha.
Sure.
Implement it there too.
Sure. Dr. Bapat, you wanted to add?
Yeah, so just an added for what Dr. Patankar said to the theme. So I personally feel Indians lack insight about health. This is a bold statement, but I think that's very true. We are digitally savvy, we are savvy about finances, but we don't have that much inclination to learn about your own body and what's good for you. Like we said, khate pite ghar ka hai, that means you are good. There is good to have some amount of weight on you. So the younger age group, maybe 25 to 45, this is when you are likely to put on more weight. People who sit for a long time, college students, young IT people who have sedentary job. So maybe more focused can be, these part of a subset of people who are likely to put on weight. In addition to another group of women who are at home and who don't pay much attention to their food habits. So I think these two groups of people should be focused for prevention of having overweight. I think you're mute, Rajeshri. You're muted.
We are a couple of hours into this program, so I mean, this is the way we really wanted to celebrate the Obesity Day. Instead of celebrating it, really taking forward the theme, as Dr. Patankar mentioned. So before we actually close the program, one-liner takeaways from each of you. And, I would, in fact, since we have Dr. Basu and Dr. Bhatkande and also Dr. Chaudhary, we'll have all of them sort of, you all can have takeaways. And I think Dr. Chaudhary can be the last because the senior most, and we will have him end the program. Whoever wants to start.
So
I
maybe
think
one liner from my side. Yeah,
Yes.
ma'am, please go
Yes.
ahead. Please go ahead.
so. I think respect your body. So it's been given to you, so you need to maintain it well. It goes in with our spirituality also. So शरीर मिळालाय त्याचा चांगला सांभाळ करा. It's not your own, so maintain it well. Yeah, that's it.
Dr. Prashant?
So maybe like a surgeon says that if you cannot maintain it, we will take care of it.
No, I will say prevention is better than cure. So rather than going to Prashant, you first try to take care of yourself. So that
So, but people who
stage
have
should not happen.
Come to me.
No, I am just joking. I am saying that prevention is better than cure.
100%, 100%. I always end my talk at that prevention is always better than cure. Together we should fight obesity.
Yeah.
And that should be the motto.
So I think we'll also have Dr. Basu give his takeaway for us.
Well,
Can we pin him?
the thing is,
Can we pin him?
the thing is, I would say two little things. This is a 60-year-old man, and I've been doing metabolic science. In fact, I started my life in preventive cardiology, and I realized that it is all of us who are not actually putting the right things in the right place, and we are now doing preventive cardiology. Why did it all happen? Why did the plaque actually ensue? So we must always remember that one should eat to live and not live to eat. That's the old Benjamin Franklin quote. And the other point is, we should start by doing exactly what's just barely necessary, and then do what is possible, and finally we can make impossible things happen. So this is a process, and we will have to start it from the school level, as Didi pointed out. But Maharashtra is doing it. I'll be very keen. I've been in charity for the last 20 years, and my whole purpose is to basically prevent diabetes. 20 years we're doing this in Bengal. My slogan, I'll be very happy to share, and you'll also be glad to know. उम्र है 30 साल, मधुमेह का जांच हर साल, गर्भवती हो जब, शक्कर जांच जरूर तब. We formed these slogans in 2008. In 2012, Ghulam Nabi Saab, he called me and he incorporated these slogans in the NPCDCS. I've been trying to work on this front. I need all of your support. I need to make the country, my ailing country, a better place to live in. So, Rajashri, thanks for this program on a very auspicious day. And we should really, make sure that this day, the obesity day, the word obesity should actually go out of, circuit, should be removed and erased from the dictionary in some years.
Okay, over to Dr. Bhatkande, ma'am.
Rajeshri, I think you've got a wonderful panel and participant present here today. This should be the advocacy group.
Yep.
All that has been said today should be made into a paper and presented to the health department, because it really should be taken very, very seriously. Sleep apnea, so many things that are, directly linked with obesity. So I think we should, this is a beautiful group. Thank you for inviting me to listen in. And I think just make it an advocacy group.
Sure.
Get everybody's thing. Devis has already said that he's already done things like slogans and things. And Nitin is anyway into obesity for so many decades now. So I think Mukta, all of them, Prashant, I mean, if they were to give guidelines, they were to give directives, take it, make an advocacy.
Yes.
We need to now go from individual practice to public health. We need to do that.
Sure. Ma'am,
Great. Thank you so much.
That's absolutely coming up next. And I'll have Dr. Nanaseth Chaudhary end the program for us. Just hats off to him. He's living it. We all talk about living well. We talk about being slim, and there he is. He's our 100 years goal. We should really look at him. Mahesh, can you pin, sir?
Hello,
Yes, sir.
can you hear me?
Yes, sir.
Good morning or good noon. On the eve of World Obesity Day, जरा बोलूया लठ्ठपणावर. Panel, interesting, each one having his own forte to cure obesity. I am one of the unique one whose journey started from the operation table, operating on peptic ulcers, cutting the stomach, seeing the results, what happens to nutrition, weight loss, and even tuberculosis because of low health. From operation table to dining table. How it happened? An orthopedic surgeon told me that in his outpatient department, those who come with knee joint pain, cervical pain, and backaches, 80% of the women are obese and 60% of the men are obese. And when he mentioned to me this, after my retirement, 8 years back, I took up to the problem of obesity, and my main patients were from the orthopedic department who could not have been asked to do any kind of exercise except maybe some kind of pranayama and yoga, which they can do sitting on the chair or on the bed. So I looked at this problem as a surgeon, and when I studied the bariatric surgery, I thought, why should you not train the stomach rather than cut the stomach? And therefore, for last 8 years, I am following the method of restricted time eating, which we also call intermittent eating, which also goes into the category of 2 major meals. But I am very much particular that they should resort to the diet which I call it Harita Kranti, SSS. Use all the vegetables and fruits, multicolored, which are grown in the sunlight, which have very low glycemic index, maximum fibers, vitamins, and colorful ones have phytochemicals. So let your meal start with either a smoothie, a salad, rainbow salad with sprouted thing as proteins and good fat like coconut oil or olive oil, or soup. So the 3S should be your part of the first meal, then a small plate, and avoid wheat altogether. Go into the millets and trick your stomach and the brain. Mindful eating 32 times. So the mastication muscles give an impression to the brain that I have eaten enough. And take the upper layer of your jawar bajra roti and make it into 2. Cheat. Take half and make it into 1 and use lots of vegetables. So SSS. Avoid the, as you promptly said, kadhai, deep fried stuff. Batate vada, samosa, kachori, bhajia, they are all causing craving. Don't bother about the word junk. Anything that you get craving of is bad for you. Now, whether it is S, salty food, whether it is S, sugary food, or whether it is O, SOS, deep fried food. With this intermittent fasting and low carb diet only twice, and some very good preparations how to get over your appetite. What do you take in the afternoon? Chiuda, masala, what not. But we have found out a very पातळ ताक आणि त्याच्यामध्ये राजगिऱ्याचा लाह्यांचे 2 चमचे आणि सुंदरपैकी मीठ आणि जिरं. It is very, very well satisfying and it does not. So I am telling people that your body is meant to be on 2 kinds of fuels. One is the sugar and one is तुम्ही साठवलेली पोटावरची माया and the liver fat. जेव्हा तुम्ही साठवलेली माया वापरायची असेल तर येणारी साखर कमी करा, म्हणजे माया वापराल. एक्झाम्पल, पैसा आला, साठवला कपाटात, बँकेत आणि FDR फिक्स्ड डिपॉझिट. तुम्ही समवलेली माया, द obesity under the skin, umbilical obesity and fatty liver. If you stop taking anything that produces sugar, you will survive only on your earned reputation, the fat. ही जमवलेली माया तेव्हाच निघेल जेव्हा तुमची बॉडी, तुमची गाडी साखरेवरून सुटून फॅट वरती येईल आणि तुम्ही कीटोन वरती जगाल. आणि ह्याच्यासाठी मी खूप अभ्यास केला, जैन मुनींचा अभ्यास केला, महात्मा गांधींचे फास्ट अभ्यास केले आणि कम्पॅरेटिव्हली, सॉरी डॉक्टर साळवी, कंपॅरिझन बिटवीन बिरियाट्रिक सर्जरी अँड उपवास लंघन. उपवास लंघन मध्ये पोटाचा आकार कायम राहतो, पण भुकेचा संप्रेरक नियंत्रणात येतो. इन्शुलिन दोघांमध्येही कमी होतं, पण उपवासाने ग्रोथ हार्मोन वाढतो, चरबी जळायला मदत होते. टेस्टेस्ट्रॉन फक्त आणि फक्त उपवासाने कमी होतो. ब्रेन डिराइव्ड न्यूरोपॅथिक हॉर्मोन्स ओनली अँड ओनली बाय फास्टिंग. प्रतिकार शक्ती ओनली बाय फास्टिंग. इन्फ्लेमेशन ओनली बाय फास्टिंग. सार्कोपिनिया होत नाही बाय फास्टिंग. BMR कमी होतो, बेटल मेटाबॉलिक रेट बाय फास्टिंग. हाडाचा घनपडा वाढतो बाय फास्टिंग ओनली. कमी उष्मांक खाता दीर्घायू होता. उलट बिरियाट्रिक सर्जरीनी आयुष्य कमी होतं. ऑटोफॅजी, स्वभिक्षण, सफाई कामगार सक्षम होतात उपवासाने. कर्कपेशी संहार होतो उपवासाने. बाकी तर रक्तातली साखर, वजन कमी होणं हे दोघंही करू शकतात. खर्च नगण्य, जीवाला धोका अजिबात नाही, दुष्परिणाम अजिबात नाही, वजन परत वाढत नाही. सो आय हॅव this kind of experience at this age, from surgery to a person who is guiding people not to accept fat and fit. कोणाच्याही पोटावरून हात फिरून सांगतो, बाळा बाई हे जरा कमी कर. माझ्या पुस्तकाचं नाव आहे लई भारी, लई भारी, पॉप्युलर प्रकाशन. त्यामुळे थँक्यू व्हेरी मच. आपण सगळे मिळून सारे जण जगातला चरबी लोकांची कमवूया, चरबीवाल्या लोकांची मस्ती जिरवूया आणि पैशाचा अपव्यय, हेल्थ केअर सिस्टीमवरचा जोर, 10 तऱ्हेचे मेटाबॉलिक डिसऑर्डर्स NCD, 10 तोंडी रावण तुम्हाला गिळायला बसलेला आहे, ज्याचं ओरिजिन फक्त आणि फक्त ओबेसिटी पासून सुरू होतं आणि मग डायबिटीस अँड कॉम्प्लिकेशन्स. थँक्यू राजश्री. It was pleasure to hear people who are working on these lines. Each one has his own experience and whatever suits their patient. One size does not fit all. आणि जो माणूस मनापासून ते करतो, he does SU and he becomes my volunteer. Now I don't have to tell them. We don't need a doctor to treat diseases including diabetes. If you know what causes your sugar in the blood or a fat converted from sugar, you have two sides of the same coin. Therefore, I think we all are now geared up. जरा बोलूया लठ्ठपणावर. लठ्ठपणा हा रोग आहे. 10 रोगांचं 10 तोंडी रावण सुरुवात आहे, मूळ आहे, जड आहे लठ्ठपणात आणि डाएटमध्ये. ज्यांना एक्सरसाइज करता येतो त्यांनी जरूर करावं, पण यो इफेक्ट विथ एक्सरसाइज इज मोर. आणि एक्सरसाइज वाले सुद्धा जेव्हा गुडघे दुखायला लागतात, फॉर्मर टेनिस प्लेअर, बॅडमिंटन प्लेअर, क्रिकेट प्लेअर, दे आर माय पेशंट्स, की खेळत होतो तेव्हा ठीक होतो, म्हणून म्हटलं बाळा ठीक आहे, आता खेळू शकत नाही, आता फक्त गो इन टू द इनटेक अँड नॉट ऑन द आउटपुट. खर्च करण्यावरती लक्ष न देता आमदानीवरती लक्ष ठेवा. काय खाता आणि ज्यांनी साखर तयार होते आणि चरबी मात्र जपून राहते, तो स्टार्ट युझिंग युअर चरबी ॲज युअर फ्युएल. थँक्यू राजश्री.
On this note, I think I would like to thank all the audience and the expert speakers who joined in today and making this program a real success. And we look forward to taking this dialogue further and pursue this further as a public health program. Thank you very much, everyone, for joining us. I'd actually end the program by playing a short video of Energia and the team who supports us in running these programs. So, on that note, thank you, everyone.
उद्या obesity day आहे. इंटरव्ह्यू होता नाही नाही वेस्ट ऑफ होता 4 मुंबईचे स्पेशलिस्ट